What's going on, everyone? This is Gianfranco Froyo. Welcome to the cardiology section. I'm going to do my best to guide you through some of these tough principles with drawings and pictures to keep everything animated and more interactive. We'll strive for minimal memorization, but in the embryology section, there are some facts you just have to cram into your head. So let's go ahead and get those out of the way. First part of the chapter is an intimidating table of cardiac structures and the embryological derivatives. Let's discuss the contents of the table individually. The first one isn't that bad at all. The arterial trunk, or the truncus arteriosus, will split into two. It will split into the pulmonary artery and the ascending aorta. Now next up, our book says that the bulbus cordis, here, forms the smooth parts of the left and the right ventricular outflow tracts. That's easy to visualize here because the central part of the bulbus cordis becomes very conical in shape, hence the name conus cordis. It will directly feed blood into the truncus arteriosus, and a cone is a very smooth structure. It will create very laminar flow, and we want that for it to flow out of the truncus arteriosus, which will split into the pulmonary and arterial trunks. It should make sense that this conically shaped conus cordis is going to form the smooth parts of the left and the right ventricular outflow tracts. While we still have this image up, let's talk about the next thing on your table, the primitive atrium. The primitive atrium will split and develop into the trabeculated part of the left and the right atrium. Now, what do we mean about trabeculations? Trabeculations are these large septations of columnar muscular tissue. Here we're talking about the trabeculations in the ventricle, but they also exist in the atrium. Now the smooth parts of the atrium, you see that looks very smooth, are formed by structures that are going to be dumping blood into the atria. And this is the right horn of the sinus venosus and the primitive pulmonary vein. So also on this image, you can appreciate how the ventricle is going to swing around to become more anterior to the atrium, and the atrium will swing back towards the posterior side of the heart. This ventricle will split to form the trabeculated, not the smooth, parts of the left and right ventricles. Remember, the smooth part of the left and right ventricular outflow tracts are formed by the conus cordis, which is derived from the middle segment of the bulbus cordis. What about some of the venous embryology? This image represents the primitive veins in embryological development. To orient ourselves, let's remember that the sinus venosus becomes part of the right atrium. Its remnant is called the sinus venerum. The sinus venosus is where the superior vena cava will come in from above, and the inferior vena cava will come in from below. So sinus venosus literally means bag of veins, which is exactly what it looks like in this picture. Know how all of the veins converge to drain into this one bag, the sinus venosus. So the sinus venosus has two horns. Anatomically, this is the right and this is the left horn. The right horn of the sinus venosus becomes incorporated into the right atrium. It returns blood to the right side of the heart. After it has become part of the right atrium, again, we call it not sinus venosus, but sinus venerum. It is a remnant. Blood flow into the right atrium needs to be smooth and laminar, which is why the right horn becomes the smooth part of the right atrium, not the trabeculated part. Now what about the left horn? The left horn of the sinus venosus becomes the coronary sinus. This long structure here is the right anterior cardinal vein. It joins this other cardinal vein coming from above. When two cardinal veins come together, you form this here. This is a common cardinal vein, also called the duct of Cuvier because he was the first dude to discover common cardinal veins. So the combination of this right anterior cardinal vein plus the common cardinal vein will give you the superior vena cava. And this makes a lot of sense to us, right? because the superior vena cava drains into the right side of the heart. The right horn of the sinus venosus becomes incorporated into the right atrium. Superior vena cava drains into the right atrium, and part of that right atrium is a remnant of the right horn of the sinus venosus. So notice how the structures from the superior vena cava return blood to the right horn of the sinus venosus. The right horn of the sinus venosus becomes the smooth part of the right atrium. And what dumps blood in the smooth part of the atrium in an adult? The superior vena cava. So let's move on to heart morphogenesis. And let's begin with the development of the heart. The heart begins as a simple tube. You can see this here. It is lined with endothelial cells and myoblast. It is the first functional organ in the embryo when it starts beating in the 4th week. I remember this because we need blood for the rest of our organs to develop. So this is the first organ to develop at the 4th week, and we need it for the development of other organs. So the top part of the primary heart tube will bend down out of the screen towards us and to the right, while the inferior part will swing up into the screen posteriorly and up to the left. This is the cardiac looping that they talk about. Test examiners are not going to ask you which direction cardiac looping occurs. Rather, expect to see a CT image of the thorax like this, or a CT abdomen like this. None of us are radiologists, but from the CT scans, you should notice something. These organs are in the opposite location that you would expect. So in the CT thorax, notice how the heart is sitting towards the right side of the chest. We call this dextrocardia because dextro means right in Latin. In the abdominal CT, note how the spleen and the liver are switched. Normally the liver sits on the right side and the spleen sits on the left side. This is how test examiners are going to guide you to make a diagnosis of Cardiovascular syndrome. Do you remember the pathophysiology? Cardiovascular syndrome is due to a defect in the microtubule protein called left to right dynein. Without a properly functioning microtubule, cilia cannot function in cellular motility, fluid transport, and signal transduction pathways. This particular left to right dynein is called left to right because it is critical in determining the positions of organs either on the left side or the right side of the body. Without a properly functioning protein, guess what happens? We get situs inversus. Situs inversus is just a Latin term for inverted sides. This is normal. Note how in A, everything is switched around. The heart is now switched to the right side of the chest. The 3 lobes of the left lung are now on the right side. Also, note how the visceral organs are switched around. You need to be ready to see this in the form of a CT scan and then make an appropriate connection to the biochemistry section and diagnose Cardiovasculars. So let's keep rolling to another high-yield part of the book. Alright, now let's move on to septation of the chambers, starting with the atria. The names of the structures involved in the development of the atria will guide your understanding of what initially seems to be a rather confusing sequence of events. So a segment of tissue begins to grow from the top of the atria. This is the septum primum. It's the first septum, so it is called the primum, which is first in Latin. The septum primum begins to grow downwards towards the endocardial cushion that is sitting in the atrioventricular canal. Now pause for a second and check out this now smaller communication between the left and right atrium. This is called the foramen primum. It is the first small hole that we've encountered in this process. Septum primum means first septum. Foramen primum means the first hole. So as the septum primum continues to grow downwards towards the endocardial cushion, this foramen primum is gone. Now there is going to be apoptosis in the superior part of the septum primum. We must degenerate this part to create a new hole so blood can flow between the right and left sides, because we obliterated the foramen primum. What is this new hole going to be called? The foramen secundum. Why isn't it called the foramen ovale? We need one more step before we can call this perforation in the septum primum the foramen ovale. So another septum, called the septum secundum, will grow down from the top of the atria along the right side of the septum primum. So here was the first septum. Now is the second septum. Essentially, it comes down like a crescent-shaped curtain over the foramen secundum. The way it sits over the foramen secundum is like a curtain, making the foramen secundum now look more oval in shape. Anatomists saw this, and they decided to name the foramen secundum the foramen ovale. Let's quickly review using another diagram so that we really know this stuff well. So here is the septum primum growing towards the endocardial cushion that is sitting in the atrioventricular canal. Note how we have the foramen or ostium primum here. In the second image, the septum primum has fused with the endocardial cushion, and an area of apoptosis in the superior part of the septum primum formed this new communication called the ostium secundum or foramen secundum. The septum secundum is growing down on the right side towards this endocardial cushion, and it stops. So why does all of this happen? To create a pressure valve. So the remnant of the septum primum here will act as a unidirectional pressure valve covering the foramen ovale. We do this to prevent blood from flowing from the left atrium back into the right atrium. So any increase in pressure in the left atrium will push the valve shut to prevent any undesired flow from left to right. So as you can see, increase the pressure, blood will try to flow, and it'll push this valve against the septum secundum. So there is no problem with flow from right to left because we want oxygenated blood to bypass the pulmonary circulation by going straight into the left atrium through the foramen ovale. After birth, the pressures on the right side will go from very high to very low. So there will be a permanent pressure gradient from left to right because the right side pressures will be so low. This means that the septum primum will be continuously pushed up against the septum secundum. Eventually, the two will fuse together and form one single division of the left and the right side. The remnant of the foramen ovale is going to be called the fossa ovalis. It is a small depression that you can see in the atrium. Now what happens if this fusion does not occur and you do not get a fossa ovalis? So if fusion of this septum primum and the septum secundum does not occur, we do not get a fossa ovalis. Instead, we have a patent foramen ovale. This is now an abnormal communication after birth between the right and the left atrium. It will allow deoxygenated blood from the venous circulation to bypass the right ventricular and pulmonary circulation and go straight into the left atrium. So how are you going to be tested on this? Like this. So a 22-year-old male with factor V Leiden presents after returning from his around-the-world vacation with new onset hemiparesis of his left side. After performing a complete neurological workup, you confirm he has suffered an ischemic stroke. What is the most likely etiology of this patient's disease process? This question is kind of a stretch, but it is testing your ability to combine your knowledge of a coagulopathy in factor V Leiden and cardiac embryology. This patient just finished a long flight around the world, which should make you think about leg stasis and Virchow's triad. So when you combine stasis with a coagulopathy like factor V Leiden, This should make you think about a DVT. The fact that he's suffering from neurological symptoms means that somehow this embolus crossed over from the venous or right side of the circulation into the left side of the circulation, and finally went up and lodged into one of the arteries of his brain and caused this left-sided hemiparesis. Now, where would the embolus go if it did not cross over because this person does not have a patent foramen ovale? Let's say it is a perfectly healthy patient. It would get trapped into one of the smaller branches of the pulmonary artery, creating a red or hemorrhagic infarct, like this one. Red infarcts occur in organs with two types of circulation, such as the lungs, the liver, the brain. Remember, the lungs receive pulmonary and bronchial arterial blood. Even though a paradoxical embolus is a clinically rare scenario, examiners love testing this kind of concept to incorporate some embryology, such as a patent foramen ovale, and a much more common clinical pathology, such as a DVT. So again, you should be thinking this patient has an abnormal communication between his right and left atria, or right and left ventricles, such as a patent foramen ovale, ASD, VSD. The patient in the vignette we discussed suffered a paradoxical embolus. It is called paradoxical because you would not expect a clot that formed on the right side to cause symptoms from the arterial circulation or left side of the heart. Now we move on to septation of the chambers in the ventricles. The two developing ventricles have very strong medial muscular walls. They're going to keep on growing. Eventually, the left and the right will meet in the center. When the medial aspects of the growing muscle meet at midline, the muscle has nowhere to go except up into the chamber. This is how we have made the muscular interventricular septum. Notice how we still have a small communication between the left and the right above this newly formed muscular interventricular septum. Now, how are we going to close this off? We don't want a communication between the left and right ventricle. So the endocardial cushion sitting directly above the muscular interventricular septum will send down a membranous sheet of tissue, represented here in blue. This is the membranous interventricular septum. So again, the endocardial cushion in the AV canal sends down a piece of membranous tissue that will fuse with the muscular interventricular septum. If one of these components fails to develop properly, we now have a defect, a communication between the left and the right side. This is abnormal. Depending on which part is missing, we either call it a muscular or a membranous defect. Both are ventricular septal defects. The most common is membranous because it is derived from the endocardial cushion. It takes very complex cellular signaling and growth to have endocardial cushion development. Now, what kind of shunt would this defect create? At birth, when we drop the pressures on the right side of the heart exponentially, and we have abnormal communication because of a defect in the membranous septum, the shunt will go from left to right because the pressures on the left side of the heart are so much higher than the right. So at birth, we have shunting from left to right across the membranous septal defect. Excellent, guys. Let's keep going. On to a flash quiz for us. The blank forms to close the interventricular foramen and separate the two ventricles. The membranous interventricular septum. We know this very well, that the inferior part of the ventricle will grow up and form a muscular septum, followed by a projection of the membranous septum from the inferior endocardial cushion. The muscular will meet the membranous to close off the communication between the right and the left ventricles. Failure to do so is most commonly due to a defect in the membranous part of the interventricular septum.